Some bleeding that we're going to talk about during pregnancy includes spontaneous abortion, ectopic pregnancies, the molar pregnancy, incompetent cervix, and placental abnormalities such as placenta previa and placental abruption, and will eventually lead to DIC or disseminated intravascular coagulation. Let's talk about early bleeding during pregnancy. The term spontaneous abortion is generally considered an interruption of the pregnancy before the age of fetal viability, which is usually considered 20 weeks. It's either spontaneous or another term elective. It's also called a miscarriage. Generally, socially, we call it a miscarriage as opposed to an abortion. It can also be defined as a fetal weight less than 500 grams. Some of the terms we use when a patient presents with a spontaneous abortion or a miscarriage. They might present to the emergency room or to the physician's office. The term threatened is a term that the patient has not delivered. The patient is not completed the abortion. So the patient presents with spotting, mild cramping, but no cervical change. In a minute we'll talk about some interventions that will help that. An inevitable abortion is where there's moderate bleeding, cramping, membranes rupture, and the cervix dilates. An incomplete abortion, there's heavy bleeding, severe cramping, some products of conception have been expelled, meaning the baby and the placenta, but some remain in the uterus. A complete abortion, there's slight bleeding, mild cramping, but the tissue's passed. That's the healthiest one that presents. A missed abortion is when the fetus has died in utero, but no products of conception have been delivered, so they're retained in the uterus. There may be no bleeding or cramping. This one can become very dangerous and deadly, actually. Recurrent spontaneous abortion is when someone has 3 or more spontaneous pregnancy losses before 20 weeks gestation. It's estimated that 10 to 15% of all pregnancies, this is all pregnancies, end in miscarriage. 50% of these are related to chromosomal abnormalities. Endocrine disorders or imbalances also attribute to a large amount of them. If we remember, we talked about the diabetic mom, and if her diabetes is uncontrolled and her blood sugars are out of control in the first trimester, she also could have a spontaneous abortion. We always want to assess the vaginal bleeding, the pain, the cramping, and whether the products of pregnancy have been passed. We're going to want to make sure these patients have a lot of rest, especially the ones who are the threatened abortion. The treatment for that is bed rest. It's often ordered, but it's not been proven to be effective in preventing progression to actual miscarriage. There's a chart on a table on 12.6, page 319, that goes through each of the management and its associated condition. So repetitive transvaginal ultrasounds and assessment of HCG and progesterone levels may be done to determine if the fetus is still alive and in the uterus. Further treatment depends on whether progression to actual miscarriage occurs. A lot of emotional support provided there. For the rest of them, assess how much bleeding, count how many pads are saturating, and save the clots. Assess pain level, the cramping amount, and intensity. The pain level increases with gestational age. We want to give the mom support, the preparation for any tests that may be done, and always provide grief counseling when that baby does pass. It may be very small. It may not seem like it was a full pregnancy, but to that couple it is the world. So please be supportive there. If the mom was Rh negative, she may need a RhoGAM or Roflac given to prevent isoimmunization for the next pregnancy. She may end up with a D&C, dilatation and curettage, to help clean out the rest of the products of conception. Discharge teaching includes cleaning the perineum after each void and bowel movement and change perineal pads often. She's going to want to shower for 2 weeks and avoid tub baths. Avoid tampons, douching, or vaginal intercourse for 2 weeks. She needs to notify the healthcare provider if an elevated temperature or foul-smelling vaginal discharge develops. eat foods high in iron and protein to promote tissue repair and red blood cell replacement, and seek support or counseling and allow herself and her partner time to grieve the loss before becoming pregnant again. As we mentioned with the threatened abortion, monitor and assessment is the same as with the spontaneous abortion. Treatment's conservative, vital signs, bed rest, vaginal rest, count pads, maybe needs an IV if they're admitted or if they come into the ER. There's something called the therapeutic abortion, and that's an elective abortion that's done when pregnancy endangers the life of the mother. But that's on a little bit different topic. Next, I'd like to talk about bleeding or cervical insufficiency. We used to refer to this as incompetent cervix. The pathophysiology isn't completely understood, but it's supposed that it's usually based on trauma, some type of previous surgery. The woman may have a genetically short cervix. That type of diagnosis is diagnosed on ultrasound, transvaginal ultrasound, and there's a term called funneling, and that's where there's an effacement of the internal os on ultrasound. But that short cervix indicates reduced cervical competence. So if a woman's had previous any treatments on her cervix at all, she may be at risk for premature cervical dilatation or cervical insufficiency. The symptoms are passive dilatation of the cervix. This woman may have had previous pregnancy losses due to this. It's painless vaginal bleeding also can occur. The medical management includes putting a cervical cerclage in around 11 to 15 weeks, and they remove it by about 37 weeks. Sometimes they'll leave it in until the patient spontaneously goes into labor. But they'll also take out this cerclage if delivery is imminent and they can't hold it off anymore. They try to get the woman as far along in her gestation as possible, though, with this suture intact. Here we're showing a picture of the procedure of how they loop that around the lower uterine segment there and close up the cervix. For nursing care, the patient will be on bed rest. We're going to make sure she has adequate hydration, keep the bladder empty, and allow vaginal rest. If they're concerned that delivery is going to happen, they'll put the patient on, if it's further along, once the cerclage is in, they'll put that patient on, the mom, on betamethasone to help mature the fetal lungs. You've heard me talk about that a lot. They may put the patient on antibiotics. In the early part, they may give her progesterone. If they're trying to stop labor contractions, she may get a tocolytic. And prophylactically, the patient may go on magnesium sulfate as a tocolytic too, to help stop those contractions. We're going to want to provide emotional support, education on the signs and symptoms. This patient is at high risk. When they get that cerclage put in, they could have premature rupture of the membranes. The patient could go into preterm labor or develop chorioamnionitis. We're going to monitor for uterine contractions after the procedure and make sure she has regular follow-ups with her OBGYN. The patient is instructed to return to the hospital if she starts having uterine contractions again, if the bag of waters breaks, if she has any leaking, or if she feels peritoneal pressure. Next, we're going to talk about ectopic pregnancy, also known as a tubal pregnancy. That's when a pregnancy is implanted outside of the uterine cavity. 95% occur in the uterine fallopian tubes, most in the ampulla or the outer third. The thing to remember here is that the uterus is the only capable organ containing and sustaining a term pregnancy. If the pregnancy implants in the tube, if it implants in the abdomen, if it implants anywhere other than in the uterus, it's not viable. It's not going to work. So the uterus is the only place that's capable of sustaining a term pregnancy. Some of the causes of this could include anything that's caused scarring, surgery, infection, pelvic inflammatory disease is one of the biggest causes from sexually transmitted infections. A fibroid could cause it to implant improperly. The signs and symptoms typical of pregnancy, and then they have pain and or spotting 6 to 8 weeks after a missed period. If it's early enough, they may be asymptomatic or tenderness. If the zygote grows in a fallopian tube, it stretches and can cause an acute rupture. That's what we're most concerned about. Most often patients present into the ER with sharp unilateral pain. That's when one of the fallopian tubes is getting ready to rupture. We're trying to catch it before it ruptures. She may have profuse vaginal bleeding. If it has ruptured, she may have referred shoulder pain because of the bleeding. If nothing's done with this patient, she could hemorrhage to death and go, and have shock. Generally, they'll present in the ER as soon as they start to feel that. It starts out as a sharp pain, and then it kind of disseminates into lower abdominal pain that's very sharp. Again, and we'll talk about medical management in a second. So they're going to, any patient of childbearing age who presents to the ER with sharp abdominal pain, unilateral on one side, needs to be checked for ectopic pregnancy. That's how we're going to save lives. So, other sites that it could implant include the ovary, the abdominal cavity, and the cervix. In order of the most frequent sites, most frequent site is the ampulla, then the isthmus, then the interstitium, the fimbria, the tubo-ovarian ligament, the ovary, the abdominal cavity, and then the cervix, which is the external os. This just shows an abdominal pregnancy. And only 5% of abdominal pregnancies reach the age of viability, which is around 20 weeks. Surgery is usually performed as soon as it's diagnosed because there is a high risk of hemorrhage anytime during the pregnancy. You can see normally it should be in that little pink part in the uterus, and now here it's in the abdominal cavity. Abdominal pain, delayed menses, and abnormal vaginal bleeding occurs approximately 6 to 8 weeks after the last normal menstrual period. Pain usually begins, as I mentioned, as a dull lower quadrant pain on one side to a sharp stabbing pain. It progresses to a diffuse, constant, severe pain that's generalized throughout the lower abdomen. Many women report, or 90% of women report light or late period of 1 to 2 weeks. Patient may present with mild to moderate dark red or brown intermittent vaginal bleeding. It occurs in about 80% of the women. If the ectopic is not diagnosed until the tube ruptures, they could have referred shoulder pain, in addition to a one-sided deep lower quadrant acute abdominal pain. Patient may exhibit signs of shock, dizziness, faintness related to the amount of bleeding or hemorrhage. If it's an abdominal pregnancy, this is kind of rare, but she may have ecchymotic blueness around the umbilical called the Cullen sign. It's undiagnosed, ruptured intra-abdominal ectopic pregnancy. The key to early detection, as I mentioned, is that every woman with abdominal pain, vaginal spotting or bleeding, and a positive pregnancy test should undergo screening for ectopic pregnancies. There's 2 types of treatment. There's medical management as well as surgical management. Medical management includes an injection of methotrexate. On box 12.5 on page 324, it discusses methotrexate, and it's the goal with medical management is to try to preserve the tube, but it's a small window where we need to destroy the products of pregnancy before the tube ruptures. If the patient has an intact tube, the medical management option, as I mentioned, is methotrexate. It's a folic acid antagonist and it stops cell division. Methotrexate has a lot of side effects. The benefits include avoidance of surgery and preservation of the patency of the uterine tube. It's a one-time IM injection, as I mentioned, lots of side effects, and it's like any other chemotherapeutic agent. It's going to make the patient not feel well. On occasion, they may give a second dose if the HCG levels aren't declining as they want. So this patient's going to return for a lab draw follow-up. Have the woman return to the clinic or office for measurements of HCG levels. If they don't decrease as they hope, they may give a second dose. Reminder that she will need to return to the office weekly for measurements of beta HCG until it's less than 15 milliunits, international units. Weekly follow-up visits may be required for several months until the desired beta HCG levels are reached. Caution her not to have vaginal intercourse. That risk of the pelvic pressure could rupture the mask until it dissolves. Also, she must avoid alcohol, folic acid, and analgesics stronger than acetaminophen because it could mask the symptoms of a tubal rupture. If the tube's ruptured, her only option to prevent any more hemorrhage is going to be a salpingectomy, which is a removal of the tube. Nursing care includes vital signs, check bleeding, start the IV with a large bore catheter, explain the procedure. Patients will complain of extreme pain. Ectopic rupture is a severe, sharp unilateral pain. The patient may experience lightheaded, dizziness, vertigo, fainting. And again, if the mom is Rh negative, she's going to need Rofalac or Rogam. Gestational trophoblastic disease or hydatidiform mole is a molar pregnancy. It occurs in 1 out of 1,000 pregnancies. The cause is unknown, but it's abnormal growth of trophoblastic tissue, including the placenta and the chorion. It's an abnormal fertilization without a viable fetus. There's 2 distinct types of hydatidiform mole. A complete or classic, the mole results from fertilization of an egg with lost or inactivated nucleus, or a partial mole can result from 2 sperm fertilizing a normal ovum. So it's a complete or partial hydatidiform mole or molar pregnancy. It's characterized by abnormal development of the placenta. The chorionic villi grow rapidly into fluid-filled, grape-like clusters. A complete mole develops from an empty ovum that contains no genetic material. A partial mole may have abnormal embryo that's usually spontaneously aborts in the first trimester. The clinical manifestation, the patient presents with vaginal bleeding. The size and the state, there's a discrepancy, the size and the date. So this uterus is larger than expected for the gestational age due to the increasing HCG. The management, most of them pass spontaneously, but if necessary, suction curettage is a safe, rapid, and effective means to getting rid of this pseudo-pregnancy, essentially. Induction of labor with oxytocin and prostaglandins are not recommended because it could cause embolization of this trophoblastic tissue. We don't want to send that circulating into the body. This is a picture of what it looks like as those cells start to see other kind of grape-like clusters. It's called a snowflake or snowstorm effect seen on transvaginal ultrasound. Also dark brown bleeding. Some call it prune juice bleeding. Preeclampsia, edema, and proteinuria diagnosed before 20 weeks. You might want to suspect hydatidiform mole. Remember we talked about the signs and symptoms with preeclampsia don't happen until after 20 weeks. Well, these symptoms will present earlier. The protein in the urine, high blood pressure, and edema. This patient is at risk for choriocarcinoma. That's a malignant gestational trophoblastic disease. It's invasive, usually metastatic, and can be fatal. It develops following the evacuation of a mole in 20% of women. So they want to postpone the next pregnancy, and they want to make sure that they've ruled out this type of cancer. They want to postpone it for at least a year and use consistent, reliable birth control. Next, I'd like to talk to you about placenta previa. Placenta previa is when the placenta implants over or near the cervical opening or the cervical os. Sometimes women can have what they call low-lying placenta. In the early parts of pregnancy, it may be picked up on ultrasound, but as that uterus grows, it lifts the placenta with it, and so it no longer is it no longer covers the cervical opening or the cervical os. It can be associated with previous uterine scars, surgery, fibroid tumors. The high-risk population include increased parity, so if someone has had a lot of births, advanced maternal age, past cesarean births, past uterine curettage from any of the conditions we just talked about, multiple gestation, that's kind of controversial. Male infants, because the placental sizes are larger in pregnancies involving male fetuses, and smokers. Concerns are hemorrhage. Antepartum, they present with painless bright red vaginal bleeding during second or third trimester. During labor, as the cervix opens, she may present with some bleeding. And in the postpartum, this patient's at risk for hemorrhage. It attaches at a site the lower segment does not contract very well. A large placenta secondary to decreased oxygen in lower segment and increased infection, placental site closer to the port of entry, meaning where the opening of the cervix, there's a greater increased chance of infection in these patients. This is always emergent. We want to be on high alert anytime a patient presents with this bright red bleeding. You want to make sure you do not do manual exam. This next slide shows a couple pictures of how it's partially occluding, a partial, marginal, partial, and complete placenta previa. Okay, the symptoms: bright red, painless bleeding. Most are diagnosed before bleeding begins by ultrasound. Abrupt, painless, bright red bleeding may begin with placenta inability to stretch to accommodate the different shapes of the lower uterine segment. May have a soft uterus, the fetal heart rate's normal, everything's fine, but the placenta loosened. Fetal oxygenation can be compromised if as that placenta gets tugged as it grows. Never attempt a vaginal or rectal examination. And depending on the gestational age and how much bleeding is occurring, that'll determine the management. So hospital or home care, the length of gestational age, if they want to preserve their pregnancy longer, if it's not to full term, they're going to use bed rest to extend the period of gestation until fetal lung maturity is achieved, then delivery is accomplished. Emergent care, if it's diagnosed during labor, we're going to institute bed rest, notify the physician or midwife, monitor the blood pressure and pulse every 15 minutes. We're going to want to start IV fluids, obtain a CBC, clotting studies, RH factor, and type and cross match. We're going to monitor contractions and fetal heart tones. Place on an external monitor. Remember, we can't use an internal monitor with these patients because we can't do any type of vag exam or rectal exam. We're going to put the external monitor on them, place them in the left lateral position, continue to monitor blood loss, save pads and linens, prepare for ultrasound diagnosis, prepare patient and family for a C-section if the previa is complete, provide emotional support. We're going to be aggressive if they're actively bleeding or if it's uncontrolled. If it's minor, if they're really not bleeding much, if they're in early parts of the pregnancy, they may be able to go home with it. If they're compliant, they're going to rest as much as possible in the left lateral position. If it's really bad, they may need to start an IV, give a blood transfusion. Again, they're going to monitor the bleeding. If it's under 34 weeks gestation, they're going to go ahead and give the betamethasone to help mature the lungs in the event they can't get the bleeding stopped, and they may have to deliver via C-section. Abruptio placentae is another bleeding disorder later in pregnancy. That's a premature separation of correctly implanted placenta. The pathophysiology includes changes in small maternal arterioles, which can equal thrombosis, that forms a clot. Then the bleeding continues to cause pressure behind that clot, and that results in the separation of a placenta from the wall of the uterus. High risk or predisposing factors include a woman of high parity, advanced maternal age, or a short umbilical cord, chronic hypertensive disease or gestational hypertension, a trauma, meaning a motor vehicle accident or maternal abuse, cocaine use or cigarette use, both are vasoconstrictors, and chorioamnitis also could cause it. It occurs approximately in 1 of 200 pregnancies. It usually occurs in the 3rd trimester or in labor. Is the cause of 15% of maternal deaths. 1/3 of the infants born to mothers with abruptio placenta die. This is a medical emergency. The cause is unknown, but it's related to, like I mentioned, hypertensive disorders, high gravida, abdominal trauma, including motor vehicle accidents, maternal battering. Any blunt trauma to the abdomen can result in a abruptio placenta. Short umbilical cord and cocaine abuse or crack abuse. I've seen it many, many times with crack abuse. The women will come in and labor because of they just got high from crack. Here we have the different types. There's a concealed hemorrhage. Not all patients present with bleeding. It can be concealed, as you can in the picture on the left. In the middle one, the partial separation, they can have some apparent bleeding, or they can have a complete sealed abruption. These are the ones that are very dangerous. By the time the woman presents, her abdomen is very, very hard and rigid, as we'll talk right here. Next slide. Sharp stabbing pain, rigid board-like abdomen, uterine tenderness, fetal heart rate abnormalities, partial or complete. She may have dark red bleeding, and because it's older blood, and fundal height changes. Now, one of the doctors I used to work with called this the shoe sign. Any type of bleeding that's just, it can be profuse. If it's a complete abruption and they're bleeding, we're in big trouble. We only have minutes in order to get this baby out in time. If it's a partial abruption, there is some still oxygenation being transferred to the baby. But again, delivery is most likely imminent. If the woman's less than 36 weeks with no fetal distress, they're going to give steroids to the mom and make sure they're going to monitor this baby and try to hold off delivery. Monitor vital signs, fetal heart rate, monitor the abdominal pain and fundal height, bed rest and monitor for uterine contractions, and count pads. The fetal bud is compromised, resulting in fetal distress, then we're going to be doing an emergency section. So we're going to prepare this mom for surgery. The management, bed rest with no vaginal exams or rectal manipulation, and notify healthcare provider immediately. Blood pressure and pulse every 15 minutes. Apply external uterine and fetal heart monitor. Position the mom in the left lateral position to improve her uterine perfusion. Closely monitor uterine contractions and fetal heart rate. Begin an IV with a 16 or 18 gauge catheter because we may need to give rapid IV infusions or blood transfusions. Review results of the CBC clotting factors, the RH factor, and make sure we have that type and cross stat available ready to go. Watch for signs of developing DIC, which I'll talk about in just a moment. Prepare for immediate C-section. Monitor blood loss, save pads and linen. Provide constant nurse surveillance and allow presence of family if available. Provide emotional support. Teach regarding the usual management and expected outcomes of abruption. Again, I've seen this done so proficiently at Hurley when I was a educator there, and also in my own patient experience. We have minutes. As soon as these patients present with this sharp abdominal pain, and possibly bleeding or not bleeding. We need to get them to surgery as quick as possible, getting all the right people involved, validating it with an ultrasound to show that there is an abruptio placenta, and getting this baby out as quick as possible. With some abnormalities of the placenta and cord. Your book kind of just briefly touches on them. These are very difficult words for me to pronounce. Maybe you will feel the same way. Succenturiatia and circumvallata. Those are two types. Battledore placenta, velamentous insertion of the placenta, which we just saw recently at Genesis and after delivery. A vasa previa, accreta, increta, and percreta, and issues of a two-vessel cord. Though the succenturatia is one or more lobes connected by blood vessels, the extra lobes may be retained. So that's where a woman continues to bleed after she's delivered, and after she's delivered the placenta, there may be we want to always examine that placenta to see if there's a missing lobe or a missing part. The next one, the circumvallata, there's no abnormalities, but it should be noted the fetal side is covered with chorion. Your textbook shows a picture of that, I believe. And the battledore is where the umbilical cord is inserted at the very edge of the placenta. The velamentous, the cord separates into single vessels before insertion. And the vasa previa, this is when the umbilical cord usually attaches directly to the placenta, and then the vessels divide. When the vessels divide before reaching the placenta, there's a greater risk of compression or tearing of those blood vessels. When an umbilical cord vessel is in front of the fetus and covers the anterior cervical os, it's called the vasa previa. The most usual sign is bright red blood at the time of the rupture of the membranes, and it's followed by severe fetal distress. This is a medical emergency. Other issues involving the placental attachment are the advanced placental implantation, such as accreta, which is a slight penetration into the placenta into the uterine wall. Increta invades the myometrium in its deep penetration, and the percreta is penetrating through myometrium, uterine perforation by the placenta. So in these situations, the woman's will have a retained placenta, so to speak, after a normal vaginal birth. And the woman may lose part of her uterus due to how embedded the placenta is into the wall of the uterus. And she may lose a window of her uterus, or she may lose all of her uterus. And this can be devastating to a family who was hoping to have more children, but they quite often don't know at the time of delivery. And two-vessel cords are sometimes associated with congenital abnormalities, cardiac and kidney. The thoughts because the same organs are being developed at the same time as cord development. And this is a picture of the succenturiate placenta. Placenta has divided into two or more lobes. The fetal vessels run between the lobes. One or more lobes may be retained after the delivery, and there, as I mentioned, the woman's at increased risk for hemorrhage. And this would be your battledore and the velamentous insertion. You can see how those blood vessels are separated. Next, I'd like to talk to you about clotting disorders in pregnancy. Normally, there's a delicate balance, homeostasis, that exists between the opposing hemostatic and fibrinolytic systems. So the hemostatic system stops the flow of blood from an injured blood vessel. The process starts with what we call a fibrin plug, then by the formation of a fibrin clot. The coagulation process involves interaction of the coagulation factors that constantly circulate in the bloodstream, in which each factor activates another factor in line, or the cascade effect. So a fibrinolytic system is the process through which the fibrin clot is split into fibrolytic degradation products and circulation is restored. So we have an area of an injured vessel, the clotting factors come in and they do a plug, a fibrin plug. Platelets are involved. They stop the bleeding at the site. They do what they need to do in order to stop the bleeding at the site. And then eventually circulation is restored as the clots are broken up enough around it, and everything's restored. So that's normally what happens. Recognition of antepartum period may decrease hemorrhagic problems in postpartum periods. So if we recognize that this patient is having issues, they may be able to stop or prevent the patient from going into DIC. DIC is disseminated intravascular coagulation, and that's a pathological form of diffuse clotting causing widespread external and internal bleeding. It's triggered by severe preeclampsia, HELLP syndrome, gram-negative sepsis. This is a busy slide, but it talks about a little bit about the pathophys as we just mentioned. Normally you're going to have a bleeding insult that occurs, causing large amounts of clotting factors to be used. Then you have widespread internal and external bleeding. So it's basically DIC is a syndrome of abnormal clotting that's systematic and pathologic. As a bleeding insult occurs, so many platelets and fibrins rush into the site. Large amounts of clotting factors, especially fibrinogen, are depleted, causing widespread external and internal bleeding. It's usually caused by endothelial damage. In OB, it's usually triggered by the release of large amounts of thromboplastin, which occurs during placental abruption, a retained dead fetus, and amniotic fluid embolus. Remember, DIC is always a secondary diagnosis. It's usually related to fetal demise, infection, and sepsis, pregnancy-induced hypertension, and abruptio placentae in OB. Other issues can cause it as well, but that's what we're focusing on right now. It's also been known to be caused or be called consumption coagulopathy because it's consuming all of the clotting factors. It's consuming everything in order to stop a bleeding event, and unfortunately it leaves the body empty to stop bleeding anywhere else. Symptoms can be bruising, bleeding from the IV site, petechiae or occult blood in the stool or blood in the urine. Our goal is to correct the cause, remove the dead fetus, monitor serum levels. They may give IV heparin, which sounds counterproductive, but they're trying to break up those other clots. And then they're going to give blood products and stuff to kind of restore the clotting ability, and they'll give vitamin K. The labs, the platelets are decreased. When the woman develops this, fibrinogen is decreased, factor V is decreased, factor VII is decreased. This is all part of that cascade, clotting cascade. Prothrombin time is prolonged. Fibrin degradation products or split products are increased, and D-dimer is increased. The symptoms, they may also have spontaneous bleeding from the gums, oozing from the IV sites, as I mentioned, urinary catheter sites, petechiae, like where they do a blood pressure, you may notice red spots underneath that. They may have a GI bleed or occult blood, as I mentioned, bloody urine, the patient may be tachycardic and have diaphoresis. We're going to observe this patient closely for complications, assess for signs of bleeding, and complications from the administration of the blood products, cardiac and hemodynamic monitoring to prevent fluid overload, and protect the woman from injury. Because renal failure is one consequence of DIC, monitor urine output with a Foley catheter. We want to make sure we're seeing at least 30 milliliters per hour. If the patient's still pregnant, we're going to keep her in her left lateral position or put a pelvic tilt underneath her. We're going to monitor the fetal heart rate. We may give oxygen via a non-rebreather at 10 liters per minute. Birth will cure DIC and as coagulation abnormalities resolve. So our goal is to get the baby out. If she's still pregnant, we have to maintain that. You don't want to take someone into C-section who's in DIC. We want to try to stabilize the patient first before we take her in for a C-section to get the baby out. But again, it's a fine balancing act and a very, very serious high-risk condition, very scary when you have a patient go into DIC who's still pregnant. Urinary tract infections is our next issue we're going to talk about. Our complications of pregnancy is asymptomatic bacteriuria. ACOG recommends that all women be tested in their first prenatal visit. It's responsible for infections that can lead to preterm labor and birth and low birth weight infants because of that preterm labor and birth. We're going to treat the women with antibiotics, and we want to make sure they get follow-up repeat cultures in about a week or two. Cystitis is a bladder infection. We want to catch it early to prevent it going up into the kidneys. in pyelonephritis, a kidney infection. It can lead to anemia, septicemia, transient renal dysfunction, gram-negative bacteria, can cause alveolar tissue to release endotoxins, which can result in pulmonary injury or adult respiratory distress syndrome. This can get out of control quickly. It develops most often in the second trimester, and hospitalization may be necessary. And just a question, a pregnant woman is being discharged from the hospital after placement of cerclage because of a history of recurrent pregnancy loss secondary to an incompetent cervix. Discharge teaching should emphasize that A, vaginal discharge should be reported immediately to her care provider. B, the presence of any uterine cramping or low backache may indicate preterm labor and should be reported. C, she will need to make arrangements for the care at home because her activity level will be restricted. Or D, she will be scheduled for a cesarean birth.